So good evening and welcome everyone to, I believe it is the 16th session of Legendo. We started this in January last year. The idea is to have monthly journal clubs that is dedicated to endometriosis. So the team, most of them you see here, I think Ben is missing and who else is missing? Uh, I
No
can't.
one.
No one. Okay. So the team will go through the recently published papers, and we normally choose 4, 5, 6 papers that are noteworthy, and we'll present them very briefly. This is not the usual journal presentation, journal clubs that will critically appraise papers. This is just to introduce the concept and go through the main findings, but we also choose one of those papers and ask the author of that paper, one of the authors of that paper, as our featured presenters. The format has been very successful because we can go through a lot, we can see what's happening in the world of endometriosis, and we can dig a little bit deeper into one or sometimes two papers. So please, if you have had a presentation and you would like to present your work either as the featured article or as one of the smaller papers, please get in touch with us. Attending Legendo is free. Our main conflict of interest is that we're supported by Karl Storz UK to organize these and to create the social media graphics and that kind of thing. This is also a joint venture with EEL, European Endometriosis League, who also helps us in advertising these sessions. What we say and what we discuss, the papers we discuss on this panel does not necessarily mean that we agree with the findings. It is, I hope, goes without saying that this is a scientific discussion around papers published. We sometimes get patients or patient advocates on these panels, so this is important to remember. Okay, today's featured presenter is my very good friend and colleague who you would know as he has been very active and has done great work and lots of really high quality publications. Professor Gernot Houdelist, who is going to talk to us about his work on the outcomes, various outcomes of both discoid excision and segmental bowel resections, and I really look forward to hearing his presentation. But before we hear from Gernot, the team is going to present a couple of articles. Let me just quickly introduce you to the team. Kyle Fleischer, Pavle Oberhofer, Avril Bachi, Mikey Adamczyk, and Flo Britton are all members of the CMIG team, Center for Endometriosis and Minimally Invasive Gynecology. And they've been working really hard in selecting the articles, and they take turns to present them. So I think, Pavle, you are presenting the first article.
Yes, that's right. Let me just set it up. So is that just the slide or the
Yes,
presenting?
yes, that's perfect.
Perfect. So the first one is a lovely study from our Italian colleagues, ultrasonographic ultrasonographic characterization of parametrial endometriosis. It's a prospective study whose primary aim was to evaluate the diagnostic accuracy of ultrasound in detecting parametrial lesions and describe these characteristics in these patients. The secondary objective was to investigate the characteristics and any associations that they might have with other nodules or indirect signs. So there were 570 patients enrolled in the study. The mean age was 36. Almost a quarter suffered with infertility. The main symptom that they had was dysmenorrhea. In terms of bowel symptoms, it was constipation. Inclusion criteria were anyone who had previous surgical or radiological diagnosis of parametrial endometriosis, and ultrasound was performed by 4 operators, with laparoscopic management being performed 1 to 2 weeks afterwards. They used the IDEA, so the International Deep Endometriosis Analysis Criteria, which consists of 4 steps. The first, looking for adenomyosis and endometriomas. Secondly, looking at ovarian mobility and ureteric dilation. Thirdly, anterior and posterior sliding sign, if it was present or absent. And finally, a thorough assessment of the anterior and posterior compartments of looking for deep endometriosis nodules. In terms of surgery, all patients were discussed in an MDT fashion with urology, colorectal support, alongside the gynecologist, and complete eradication of visible endometriosis was achieved in about 94% of the patients. Amongst the surgical procedures done, shave was performed in nearly 40%, a disc resection in 7%, and colorectal resection in 12%. A hysterectomy was also performed in about 26% of women. In terms of statistical analysis, their previous retrospective study, which they performed, showed a prevalence of about 20% of parametrial endometriosis. So a power calculation was calculated to see the number of patients required, which gave a number of 426, which is below the amount enrolled, give a 99% confidence interval with a 5% margin of error. Sensitivity, specificity, as well as positive predictive values were calculated, and chi-squared and Fisher extract tests were used for the association between parametrial and other direct and indirect deep endometriosis signs. In terms of the results were pretty impressive, with a sensitivity of 77% for detecting parametrial endometriosis, specificity of nearly 100%, positive and negative predictive values both in the high 90s, and a positive likelihood ratio of 84 and a negative likelihood ratio of 0.2. So amongst the patients enrolled, 105 had surgical diagnosis of parametrial deep endometriosis nodules, which gives an overall of about 18%, so in keeping with their previous study. Secondly, looking at the appearances, location, and size of these nodules, ultrasound found that the most common appearances were that they were mildly hypoechoic, exhibited a starry morphology, and that they had irregular margins with a low vascularization. The predominant location of these was in the deep portion of the posterior parametrial region, and in terms of size, smallest size was identified in the anterior compartment, with the largest being in the posterior and lateral regions having slightly less at 11.6 millimeters. Concomitant deep endometriosis nodules in the rectum were seen in over 60%, and ovaries were fixed to the wall in well over 2/3, with an absence of posterior sliding sign in 50%. Hydronephrosis was largely detected in the lateral parametrial nodules for about 70% of people who were seen to have that. In summary, it's a comprehensive evaluation conducted in a large cohort of patients for preoperative deep endometriosis, showing a sensitivity of over 75% and a specificity of nearly 100. The characteristics unique to these lesions were identified in more than 2/3, and they acknowledged their limitations, that it was a specialist tertiary center, and that the people performing the operation and the ultrasound were highly specialized. So needs to be repeated in more centers for us to get a broader understanding.
So I know that we have another ultrasound paper, so maybe we'll leave the discussion, a more in-depth discussion with Gernot, because that's Gernot's particular interest as well, to after that presentation. But just one thing to point out is, in a lot of these types of studies, what we see is what is possible with ultrasound. What's a big variable is the expertise of that person doing the ultrasound scan. So I sometimes think of it as, I don't know, showing some oil paint and showing Mona Lisa and say it is feasible to do Mona Lisa using oil. It really depends on the artist and the ultrasonographer, but all of these show that in expert hands, you really can do a lot with a very cheap um, modality. I don't know what you think, Gernot.
Do you hear me? Yes.
Yes.
Yes, basically I agree. I think it's a very simple, quite simple and easy at hand tool. It does not require special planning, and it has been shown to have a very high accuracy. It is operator dependent, but it's got more or less equal accuracy regarding the detection of deep nodules compared to MRI. There are some gray zones regarding barometrial disease, but ultrasonographers get more experience with that. And finally, the learning curve is very steep. We've looked at that as well. So if you would put a person in a tertiary referral center with a prevalence of bowel endometriosis of 20%, the person would need 45 supervised scans to be capable to reach a sufficient capability of picking up these lesions. So this is not rocket science. You can, of course, there are special questions that need to be solved, but what you want to know as a tertiary referral center, whether there is deep disease, whether you got a high risk surgical patient, etc., whether there's bowel disease, this is not rocket science. It can be learned quite quickly and easily.
Yeah. Okay. Perfect. Let's go to Avril.
Okay. All right. So the paper I will be presenting today is a paper by Professor Horace Roman and his team, and this was published just 2 months ago in the Journal of Minimally Invasive Gynecology. And the aim of this study was to assess the feasibility, the effectiveness, and the safety of the robotic surgical approach in the treatment of severe diaphragmatic endometriosis. So we're just going to move to the next slide. So this is a retrospective single center study. They recruited patients who were symptomatic for diaphragmatic endometriosis, had a positive histology, was treated exclusively by robotic approach, and were willing to enroll in the IFIM Endo database. And they performed the excision of diaphragmatic endometriosis separate to excision of pelvic endometriosis. And the main reasons was, number one, the position the patient was going to be in if they were excising pelvic endometriosis. It would cause difficult access into the Morrison's pouch compared to left lateral decubitus. And number two, if they were doing any bowel procedures in the pelvic endometriosis excision, then it would, if there was an early anastomotic leak, then it could cause a risk of chest contamination and mediastinitis. So these patients were treated exclusively only for the diaphragmatic endometriosis. Yes, they may have previous treatment of pelvic endometriosis. So for the next slide, this shows how Professor Roman and his team operating theater setup was. So first patient was in the left lateral decubitus at a 10% tilt angle. The Da Vinci robot was on the right side. The first port you can see over here on the left side is the bipolar forceps placed at the level of the umbilicus and along the right anterior axillary line. The scope is placed 4 centimeters above the umbilicus, and that's in the mid-clavicular line. The third port is placed in the midline, and that's about 6 to 8 centimeters above the umbilicus. So he uses 3 arms. And then the assistant port is placed in between the scope and the scissors. So these are the results that we can see. So 60 patients were recruited. Next slide, please. Sorry. 60 patients were recruited. Unsurprisingly, the main symptom is shoulder tip pain, recorded in 83% of patients. Interestingly, in terms of the MRI evaluation of the diaphragm, only 48%, 48.3% showed positive lesions on the MRI. If we look on the right table, table 2, which is the intraoperative findings, again, unsurprisingly, most of the lesions were localized on the right side. Most of them presented as foci. And then in terms of complications, Professor Roman, he and his team, they recorded one intraoperative complication, so giving it a rate of 1.7%. And this was a trocar-related liver injury and subsequent hepatic hemorrhage, leading to conversion to laparotomy. They classified early complications as those less than 30 days, late is complications arising after 30 days. There were no early complications, but in terms of late complications, about 4 cases were recorded. 3 of them were due to diaphragmatic hernias, and 1 of them was due to a pneumothorax treated with pleurodesis. So the conclusion from this paper is the radical robotic deep endometriosis excision was shown to be safe and associated with a low rate of intraoperative and postoperative related complication in 1.7% and 6.6% of cases respectively. In terms of the limitations, the authors did note that number 1, they had a short follow-up period. It was just 36 months, and they could cause an underestimation of the diaphragmatic hernias because most of the complications did occur at 12 months and 30 months, 36 months after the surgery. 12, 30, and 36 months after the surgery. So those were the cases. And then that's all from me.
There is a poll. While we have a little discussion, if you can answer that poll, that would be great. It would have been nice to have Horace. I know that he was trying to join, but he had other commitments that he did say that he might not be able to. It would be interesting to see if there is anything that he has seen in those patients that ended up with a diaphragmatic hernia, because we haven't seen that yet in ours.
Yes.
I don't know if we've done this many though. I think ours is probably, I don't know, 40, something like that. I don't know, Kyle, if you know the number, or Avril. But we haven't seen one. I don't know. Have you seen any diaphragmatic hernia, Gernot or Alan?
To be honest, I absolutely do not do diaphragmatic surgery for endometriosis, only for, ovarian cancer. And basically, we hand this over to the general surgeons who are very, very well trained with hernia surgery. So basically, these cases where you have extensive we had a couple with diaphragmatic resections where they put in a mesh or net or whatever. This is done by the general surgeons. So
us too, by the way.
I think. So I couldn't answer the question, to be honest. But I don't recall any cases. And we're talking about diaphragmatic resections. We're not talking about buzzing some endometriosis on the diaphragm.
We're talking about diaphragm. Yes, when we do that, we also do that jointly with the thoracic surgeon. So we often approach that from both bottom and top. And that's maybe a discussion for another day. But we have now seen in 3 consecutive cases that when we thought that we'd completely excised the disease from the below of the diaphragm, once we went to the top and did a VATS procedure, we could see further disease. But yes, the other thing I saw was this injury to the hepatic vein, which sounds really scary. It would have been good to see how that was managed. Have they said that in their paper, Avril? Is there a description?
No, they just mentioned that it was converted to laparotomy. That's all.
Okay. So our poll results are out. So we asked, when performing laparoscopy for endometriosis, how do you assess for diaphragmatic endometriosis? Observe at 360 pelvic survey, 45% of the audience have said that. Another 45% have said that they routinely use a 30-degree scope and reverse Trendelenburg and right shoulder up. That really does improve the visibility of the underside of the diaphragm. And 9% have said that they also manipulate the liver medially to assess the posterior part of the diaphragm, and nobody routinely dissect the falciform ligament, which I think is very rarely required unless you are actually excising the diaphragm. But the point is that a lot of diaphragmatic endometriosis can be posterior, and unless you position the patient appropriately and use a 30-degree scope, you're going to miss those. Okay, so finally, the moment we've all been waiting for, Professor Houdelis, the stage is yours, please.
So thank you very much. Can you see this? Can you see the screen now?
Yes, it's perfect.
Excellent.
Yes, that's
so thank you very much for inviting me. My task today is to talk about the issue of endometriosis or deep endometriosis associated dysfunction. So why do that? Because basically, if we treat patients with endometriosis, we either do it for fertility issues, but mainly for impairment of quality of life due to pain. And the issue of bowel dysfunction has gained more and more, I would say, recognition over the past year. So the task of our group was to have a closer look in how far this really is a problem, whether there's a correlation between the extent of disease and bowel dysfunction pain, and what is the current evidence on the surgical outcomes. So what you're seeing now is not my work, it's a teamwork, and I would like to say thank you to the team, and we have a very close collaboration with Budapest University and Attila Bokka's team. You can see Ezgi Darici, Daria Pashkanova, Rika Bruegel, Gabor Sabo, our team from Vienna, Claudia Rüsch, Marie-Louise Gößwein, and our two colorectal surgeons, Nicolas Hartig and Tudor Birsa. So thanks to your efforts. I would like to raise two main questions. The first one is, what do we know about actually pre-surgical gastrointestinal function impairment and pain? And what are the real, and this is a bit provocative, the real outcomes post-surgically? So bowel dysfunction is, or bowel function is basically controlled by the autonomous nerve supply. We've got the sympathetic, the parasympathetic part. The parasympathetic part mainly leading to voluntary relaxation of the external sphincter, a contraction of the flat muscular, whereas the sympathetic part rather leads to closure and a mechanism contrast to defecation. So bowel function is influenced by a variety of factors. It is nerve dysfunction, which could be caused by inflammatory processes or tumors, like endometriosis, but it could be also caused by a lack of mobility, caused by secondary adhesions. So the issue is very complex. And we've seen that a majority of the patients with colorectal endometriosis do fulfill criteria of LARS or LARS-like symptoms already pre-surgically. So if we look at bowel dysfunction, we should also have a look at the pre-surgical situation. And as you can see, it's not a minority. It's a veritable percentage of patients that may show bowel function impairment. So the recognized tools to look or estimate bowel dysfunction is the so-called LAS questionnaire, the lower anterior resection syndrome questionnaire, and the GI quality, which is basically recommended, the gastrointestinal quality of life index. And the question is, in how far does this bowel dysfunction, I would use this term now, really affect our patients? So what is it a real problem? And if we look at the literature, this is evidence from colorectal cancer patients. The patients do suffer or experience it quite often, but in colorectal cancer patients, there are no data on endometriosis. They general decrease of quality of life is only about 10%. So you could say we may suspect that bowel dysfunction does not significantly affect quality of life, because 10% plus minus is not such a big effect. And I found a very interesting study published 2 weeks ago by an Australian group who tried to answer the question, is there a most impactful endometriosis symptom? And they screened 900 patients with endometriosis. And basically, and very interestingly, there is no single predominant symptom of endometriosis that impacts the quality of life of these patients. It's very heterogeneous. But as you can see, if you look at the table on the right side, bowel dysfunction is only listed as the most impactful symptom in only 1% of the patients. So it is quite prevalent, but it is obviously not perceived as a major problem. The predominant problem appears to be the pain, but it appears that patients do cope quite well with bowel dysfunction. So what we just recently have been able to publish is we try to answer the question, is there a correlation between colorectal nodule size and location and the degree of defecation, pain, and bowel dysfunction? And there is no correlation. So whether you have a large nodule, a small nodule, whether it's low or whether it's high, it does not appear to make a difference. There is neither effect on pain nor on bowel dysfunction, the degree of bowel dysfunction related to the size and the height of the nodule. And how come? And we hypothesize that it is not purely the bowel nodule causing the problem, it's the whole inflammatory response. It's the whole kind of additional affection of the uterus, ovaries, etc., etc. It's the anatomical distortion, it's the immobility. It's much more complex as we think. So what do we know? It is an issue pre-surgically. It is quite common, but it does not appear to affect the quality of life of the patients relevantly pre-surgically from what we know. And to make it more difficult, you couldn't tell that the bigger the nodule, the bigger the symptom problem. That may not be the case. So what we did in the paper I'm asked to present is to look at the outcomes of surgery in terms of decrease of pain and bowel function pre and post surgically in patients undergoing surgery with colorectal endometriosis. And we looked at 162 patients. 2/3 underwent nerve and vessel sparing segmental resection, which is the predominant technique we apply, and 30% or 30 patients underwent full thickness resection. We basically rarely ever do shaving. And we looked at pain, but also loss and GI quality pre-surgically and post-surgically. And I hope this works now, because I would like to just show you the papers as such. Can you see the screen now?
Yes, we can see.
So now it doesn't open up. That's not the way I wanted to do it. Let me try this. That's better. And basically, 125 patients undergoing nerve vessel sparing segmental resection, 37 full thickness resection. And the main outcome, the prime outcome, was GI quality and loss, changes in bowel functional dysfunction.
Sorry,
And
Gernot, we are seeing the slide that is showing the paper pain, gastrointestinal function, and fertility outcomes. Is that what you want to show?
Oh, no, you should see the paper, actually. You should see my You should see my, hang on. You should see the, you should see the papers as such. Can you see this now?
No, we can see your PowerPoint presentation.
Okay. Let me try to do this again.
Yes.
So now you could see it,
yes,
is it?
Now we can see.
Okay.
Yeah.
So the primary outcome was the change in bowel function. And the main message was, as you can see, that we actually noticed a decrease in Lars-like symptoms. And we noticed an increase in GI quality scores. So to predominantly look at bowel dysfunction post-operative does not appear to make a lot of sense. And you can see now the basically perioperative like complications where the leakage rate of 1.6%, et cetera, et cetera. But there was no difference regarding either complications nor bowel function or Lars scores between the two techniques. So whether you did segmental or disc, there was no difference. And the main interesting thing was, if you look at the graph here, we did a cross table and looked at patients who did not have Lars-like symptoms and then truly developed major Lars. And as you can see, it happens, but it's very rare. It only happened in 2 patients. So the big fear that you do a corrective surgery and these patients may suffer from Lars, et cetera, as colorectal cancer patients do, did not turn out to be the major problem.
Sorry, Gernot. So that I understand this paper. So 20 patients had major Lars pre-operatively, and only 2 of those 20.
Lars-like symptoms. You could
yes, Lars-like symptoms.
Lars-like symptoms.
So you actually made 18 of those 20 better as a result of surgery.
Yes, you can see the Lars scores dropped.
Yeah.
So if you look at the cross-tabulation, the majority of the patients with Lars-like symptoms get better. And the very small percentage of patients who do not have Lars-like symptoms, do truly develop Lars.
Yeah.
So taking you back to the presentation, and I'm trying to be quick now. Sorry.
We have time, Gernot. Don't worry.
Yeah. Taking you back to the presentation, you can see that it depends on what you're looking, and it depends on when you're looking at the problem. And we did recently do a new systematic review meta-analysis of the question. There's only one being published by Quintieros in 2022, who tried to look at the outcomes of segmental resection versus discrete and shaving regarding the risk of bowel dysfunction, which means GI quality, Lars, or Wexner scores. And as you can see, the only outcome was, but the quality of evidence was quite low because mainly there are just prospective cohort studies and no RCT, only one RCT by Horace Rand's group, that conservative surgery, discrete or segmented, discrete or shaving, presented with few events of constipations, but basically there was no major difference in Lars and GI quality scores. So we basically, this is the main work by Etski Darici, and we reviewed the whole literature. And as you can see, there have been several papers on this issue being published over the past years. And we tried to answer the questions, is there a benefit of doing this technique or the other technique in terms of post-op bowel dysfunction? And if you only look at the post-operative values, if you only look at the papers or compare the post-op prevalence of LARS and GI quality? Yes, it appears that segmental resection may have a significantly higher number of LARS-like symptoms and GI quality impairment compared to for thickness discrete resection and shading. But, and we've been the first ones to look at it differently, we then looked at all the papers who also evaluated the pre-surgical values. So we compared the differences in pre and post course for the technique conservative surgery versus segmental resection. And as you can see, there is no difference. So if you compare changes in LARS scores, GI quality scores, there is no benefit or advantage of one technique, conservative surgery, discrete resection, shaving, over segmental resection. And this is, I think, what is my if bowel is a problem, but it is not a major problem, a lot of patients with endometriosis do report it, but if you look at the evidence so far, it is not rated as a main impact symptom. The majority of the patients can live with it pre-surgically. The first message. The second message is, if we look at patients and we take them to theaters and do surgery for whatever reason, we need to look at pre-surgical values. And ideally, you should use LARS and GI quality. It does not make sense to purely focus on post-operative LARS, as colorectal cancer surgeons do, for obvious reasons. You have to look at the pre-surgical situation, because endometriosis as such does cause LARS-like symptoms and GI quality impairment. But if you look at these patients and do the surgery, there does not appear to be a benefit of one technique over the other. And even more, we've been able to show that in the majority of the patients, these symptoms do indeed get better, not worse. It is only a small percentage of patients who do develop de novo LARS, de novo severe bowel dysfunction. It is very rare. Thank you very much for your attention. Can you hear me? I can't hear you.
You're muted.
No, that's because I've done the usual and I have not unmuted myself. So in your usual practice, outside
have you been able to get the presentation?
Yes, exactly. So the message was quite clear. I particularly liked how you summarized it in the end, and it makes a lot of sense. I think in most of our practices, although we ask some questions about bowel function, but I don't know how many of us routinely use LARS and GI quality for their patients preoperatively. Do you think this is something that we should do routinely?
Well, I think you should do it for two reasons. The first one is, if you do embark on colorectal surgery, there is a small but relevant risk that you treat the pain but create another problem. So if you talk to general surgeons, LARS is an issue in colorectal cancer surgery, okay?
Yes.
But we know that the story is completely different in endometriosis because it's already pre-surgical issue, but it doesn't affect the quality of life on a large scale, obviously, as far as we know. So if you perform these procedures, you want to know what the outcome is. And one outcome of colorectal surgery for deep endometriosis is not only pain reduction, it is also bowel function. And this is why I would at least use a last questionnaire. Ideally, the recommendation is to use a GI quality. And the second is also for forensic reasons, because you might have a problem because you're performing, whether it's the surgeon, you doing whatever. I'm not going to embark on this question, but you want to prove that you didn't make things worse.
Yeah, yeah.
As simple as that.
So, now, as you know, more organizations and societies are considering centralization, and they are trying to design questionnaires for preoperative assessment. So what you're saying is that questionnaire should ideally include something like LARS.
Yes, you should. I think it makes sense to evaluate bowel function or the degree of dysfunction pre-surgically in case you do colorectal surgery for deep endometriosis.
Yeah, it makes a lot of sense. It makes a lot of sense. The other question I had was the nerve and vascular preservation. How much do you think the vascular preservation, I'm assuming by that you mean not taking the IMA routinely. How much do you think the vascular preservation is?
That's a super interesting question, and we try to answer it, okay? So my very diligent colleague, Ezgi Dariti, published this systematic review in ACTA 2 years ago, and we pulled the whole evidence on leakage rates and fully for segmental resection. But there is such a large heterogeneity. You can't prove this, because if you look at the papers, some just say they did a segmental resection, some say they did nerve sparing, but only, I think, a quarter really, really clearly described preservation of the vascular supply. So this question cannot at present be answered on a large evidence-based level because the data are too heterogeneous and there are no RCTs. But I am convinced personally that at least you do not do harm if you do a very limited nerve and vessel sparing resection. And I hypothesize that it is beneficial. If look at the evidence so far, who show that the leakage rate in this, of course, leakage rates depend on height, etc., etc., etc. But I think it is beneficial, and you do not do harm.
Yeah, no, I completely agree with you. I think even if we went by just principles of surgery, that you don't sacrifice a vessel or a nerve unless you really have to. That's just.
And the question is, why do it? So of course, a lot of patients from the history, colleagues do this with their colorectal colleagues, and a colorectal surgeon does not do a nerve vessel sparing resection. There is no indication to do that. They don't do it for rectal cancer. They don't do it for diverticulitis. There is no general colorectal surgical indication for this technique.
Yeah,
it doesn't exist.
Yeah, you're absolutely correct. But the more, and that would be another reason for doing more multidisciplinary work, because when the colorectal surgeons, in my practice, I've worked with maybe 6 or 7 colorectal surgeons. All of them were initially not particularly familiar with endometriosis, but as they see the pathology and as they open their minds to what differences we have between this and colorectal cancers, they will start asking the questions. Is this step of the operation absolutely necessary in this group of patient? And they adjust their techniques. Okay. Do others have any questions? I don't see anything on the Q&A.
There is one chat question. Please do feel free to ask one. Okay.
Yeah. Okay, so maybe we can leave some more discussion for in 15 minutes when we finish. Let's go through the other two papers that we have. Pavle, it's your turn. Thank you very much, Gernot. That was an amazing work. Okay, Pavle, you share screen.
Yep, just setting up. Can everyone see?
Yep.
Great. So this is a second study from our colleagues in Rome that was published in July of this year.
Sorry, Pavle, we're seeing the first slide. Okay.
Sorry, just sliding through.
Yeah, that's the one. Yeah.
That's the one. Sorry, apologies. So that was published in May of this year, and it's the reproducibility of the hashtag Enzian classification by transvaginal ultrasound and its correlation with symptoms. So the aim of the study was basically to see whether it was feasible and whether there was inter-observer reproducibility of the classification using ultrasound for people who hadn't had any surgical or hormonal treatment beforehand. The study carried out from January to September, from 2020 to 2022, and 200 patients were enrolled with inclusion criteria predominantly being that they've had one ultrasound feature of endometriosis, they weren't pregnant and no previous abdominal surgery, and exclusion criteria, obviously, if they've had any of these. Symptoms were recorded using a visual analog scale, and the Enzian classification was applied to classify all pelvic endometriosis. Mean age of the patients was 34 and 70% were nulliparous. Additionally, 52 patients underwent real-time ultrasound by two experienced sonographers to assess the reproducibility of the classification. The sonographers were blinded to each other's findings, but they weren't blinded to the patient's symptoms. So, in terms of clinical history, symptoms such as dysmenorrhea, dyspareunia, dysuria, and bowel symptoms were evaluated using the VAS, and a score of equal or greater to 5 indicated the presence of symptoms. Bowel symptoms were specifically classified based on various reported issues, and the presence of heavy menstrual bleeding was noted as a significant symptom. In terms of mapping, they used two previous mapping sheets done by Guerrero and Exacutos to look for all locations of endometriosis, and they thoroughly investigated, I won't list them all out, they're there on the slide, but all the areas for the study. This is the Enzian classification that we all know from 2019, but within this study, they excluded tubal patency, and they also excluded the detection of peritoneal endometriosis. The study established clear grading criteria for lesions based on their size and extent, facilitating accurate classification. So, for example, in compartment T, adhesions were suspected during the scan if the ovaries and/or the uterus appeared to be fixed to adjacent structures whilst performing an abdominal palpation, whereas in the compartment FU, if a ureteral diameter was greater or equal to 6 millimeters, it was seen as a congestion sign correlating with obstruction. For statistical analysis, the main one that we were interested in was the inter-observer agreement, and for this they used the Cohen-K index, and results indicated an excellent agreement between most compartments. The symptom prevalence was that in 95% of patients there was dysmenorrhea, followed by dyspareunia and heavy menstrual bleeding in half of them. Notably, only 5 patients reported dysuria, so this wasn't included in the statistical analysis. And in terms of the compartments involved, the most involved compartments were the uterosacral, cardinal ligaments, and pelvic sidewall, so zone B on the left-hand side, which was seen in 64% of patients. FA, which is adenomyosis, was in over half, and T and O, so tuberovarian conditions in ovary, were on the left. There was a statistically significant difference in the representation of left versus right for B and T, but not for O. Finally, they use these quite nice radar plots to describe and to show the correlation between locations of the endometriosis that they did see using the NCN scoring, so A, B, C, D, F, A, and T, and also with the symptoms present. So if you look, for example, in box D, you can see that with dyspareunia and bowel symptoms, the bigger the point to the letter, the more common this was seen. So we can see that it was really common to see the presence in zone B and zone T for dyspareunia and bowel symptoms, whereas for heavy menstrual bleeding, understandably, with adenomyosis, it was much more prevalent at A. In terms of the inter-observer agreement, the K-index was really good and ranging from 0.8 to 1 for most compartments. However, in A and FA, this was slightly reduced at 0.6 to 0.8. And the study acknowledges that this might be because vaginal endometriotic foci and mild adenomyosis can sometimes be difficult to be detected on transvaginal ultrasound. So in summary, the study confirmed that the #NCN classification was easy to use and reproducible amongst different operators. Dysmenorrhea was a non-specific symptom, but certain symptoms were more present in different compartments, and that these could be used to form a new perspective on the severity of endometriosis and lead to improved classification and more effective management of patients. Finally, the limitations were they knew that they needed a larger sample size and obviously multi-center studies to confirm their findings. And that's it from me.
Thank you very much. So we have another poll while the audience will answer the poll, which is what classification system does your radiology sonology team use? And we've cheekily, oh, you haven't included Venus in there. That is not acceptable. Anyway, so while they're doing that, I will see what Gernot can tell us about the recent paper that you published, the consensus paper, Gernot. That was a really nice achievement of the whole team. But basically, what you said in your paper was also similar. No?
What do you mean now? The correlation with symptoms, or
The correlation with symptoms and the use of NCN, #NCN.
yes. So to briefly report on that, we did a previous paper which was published in RBM Online 5 years ago. And yes, there was a correlation between site and extent of disease and the certain symptoms, but the correlation coefficients have been significant, but still very low. So I think, or I raise a question. There are constant, I would say, efforts to create or find a score or a classification system that does correlate with symptoms. But I think this is nonsense, because the disease as such does not correlate with symptoms or certain symptoms. It's very heterogeneous. It's much more difficult than we think. So I think on one hand, you do describe the extent of the disease anatomically or volume-wise or topographically accurately, whether you use NCN or ASRM or AGL. So there are various ways, okay? And I'm not going to embark on the discussion whether this classification is beneficial over the other. But I think that the effort to find a correlation or to find an ideal score that can be used and always will correlate with symptomatology does not make sense.
Yeah, I agree. I wrote an editorial a couple of years ago exactly on that topic, that it's not an advantage of a classification system to correlate with symptoms, because if it does, I would question that classification
Yes,
system.
I agree.
Because, yeah, the disease doesn't play that game. So
Exactly,
if classification
yeah.
proves otherwise, you should wonder why. Okay, we have only 3 minutes to go, so let's go through our last slide, and there is one question that hopefully we can cover.
Okay, so hi guys. My paper is
Oh, by
by
the way, just sorry, before you start, so
yeah.
not surprisingly, most of the audience use hashtag NZN 50%, 10% IDEA, 10% RASRM, and 95% use Venus. But that has not been shown in this slide. I'm joking, by the way.
May I just briefly add a comment, which is very important?
Yes.
There is a constant misunderstanding. Idea and ancient is not contradictory. Idea is the terminology, the grammar. It's about terms and definitions for deep endo and ultrasound. So you could use idea for whatever, but you have to use idea in order to use ancient.
Yes.
So it is not quite correct to say, yeah, you use idea and that not use ancient. You're only able to use the ancient with sonography if you know about the idea criteria.
Yes. No, no, I understand that. Idea is basically an idea of how to systematically look
Yeah,
for
it's like
different
it's a
compartments.
grammar, you know,
Yeah,
a
yeah.
grammar for a
It's
language.
not a classification system
Yeah.
or, yeah, sure. While we're at it, before you present, Avril, Roya Padmer, my ex-fellow who used to be in Iran, now in Canada, just want some clarification, Gernot, about, so are you saying we should try and ligate superior rectal artery? I think you mean inferior mesenteric artery, because we don't go down to superior rectal artery. Superior rectal artery would be a branch of IMA. But yeah, go on.
Me.
No, Gernot.
Yeah.
Oh yes, I see
The
the
question
question.
is,
No.
should
Yeah.
we or should we not?
Yes, I would not. I would try and preserve as much fat and vascular tissue as possible. That's it.
Yeah, I agree.
Unless you have to get more bile down into the small pelvis, because otherwise then you have to mobilize the left colonic flexure and probably cut the inferior mesenteric artery to get more loops down. But in the majority of the patients, you can preserve the complete vascular supply, even in large segments.
And Kartika Lestari is asking, so if the size and location does not correlate, is it possible that the symptoms is due to overactivation or sensitization of autonomic nerves
Yes.
around the lesion?
Yes.
Yeah.
There is good evidence showing that, you do have even irritation, overactive bladder symptoms in patients with deep parametric disease because of the irritation of the S2 to S4 parasympathetic supply. There is good evidence that patients do have bowel or defecation pains in the absence of bowel endometriosis because they do have a large parametral or uterosacral ligament nodules. So I think it is a combination of irritation of the autonomous nerve supply by endometriosis, by general inflammatory response, and in combination with adhesion and the lack of mobility. And there's been a very nice article by Ross Rahman in the AJOC a couple of years ago. It is not purely about the size of the nodule and the height. This is not appears to be the relevant issue regarding bowel function and pain, defecation pain.
Okay.
So the good question. I was actually going to ask a very similar question in a second about the fact that that group of patients that had LAS-like syndrome that got better after the resection, did those patients also have hyper sort of activity or hypersensitivity of bladder at the same time as well as rectum, leading to sort of S3 nodules?
So I think that the reason why they get better, okay, probably is not even related to the bowel surgery. it's probably related to the endometriosis surgery,
Mm.
you know, because the majority of these patients had endometriomas, peritoneal disease, etc., 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 etc. So this is one aspect. And the other one is that there is some evidence saying that the hypersensitivity of the bladder, patients complaining of OAB symptoms, of frequency, urgency, etc., are predominantly those with deep perimetral disease.
Okay. Yeah.
Perfect. Avril, the last one.
Okay. Right. So my paper is by Professor Scambia and his team from Rome. And the main aim of this paper was to assess the surgical outcomes in terms of complications in women undergoing nerve-sparing parametrectomy based on the lateral and caudal extension of the procedure. So next slide, please. So this was a prospective single-center study. They included all patients who had ultrasound confirmed parametrial endometriosis and were undergoing for surgery for them. They recruited them between September 2020 to June 2023, and they excluded patients who were under 18, are not sexually active, previous bowel or bladder resection or ureteric reimplantation, and previous pelvic radiotherapy. So next slide, please. So this slide is just for a little bit of the refresher of the anatomical landmarks that they plan to use. So the main anatomical landmark they are using is, as you can see here, the hypogastric nerve, which is wrapped in the presacral fascia. And then caudally and laterally to it, you can see the sacral roots covered by the hypogastric fascia, labeled HF. And then more ventrally, you can see the medial rectal artery passing through the lateral ligament of the rectum, labeled as LLR. On the picture on the right side, this on the top figure, so they're just giving us examples. So the top figure bit, so the endometriotic nodule is in the yellow hexagon. And the right hypogastric nerve is the one that is labeled with 1 star, and this is covered by the presacral fascia. And the ureter is the one that's lateral to it, where there's 2 stars on top of it. And then on the image at the bottom, the one in the circle is the endometriotic nodule on the lateral ligament of the rectum. And then with the yellow dotted lines, you can see the middle rectal artery, and caudally and laterally to it is the branch of the inferior hypogastric plexus. So these, next slide, please. So these are the definitions that they're using for the different types of parametrectomy that they perform. So for superficial parametrectomy, it's anything medial to the presacral fascia that's covering the hypogastric nerve, and the cranial to the middle rectal artery. DP1 is excision of tissues lateral to the presacral fascia. DP2 is anything caudal to the MRA, and DP3 is where they use the hypogastric fascia, and the procedure was deeper and lateral to the fascia. So next paragraph, please. Next slide, please. So this is the image of the intraoperative complications. So what they found was urinary tract infection and bladder voiding deficit was statistically different between these groups. So DP2 had, so in terms of urinary tract infection, DP2 had a rate of 20%. And in terms of bladder voiding deficit, DP2 had a rate again of 20%, DP3 is 30%. They also looked at the number of days of autocatheterization, which is the circle at the bottom end of the table. And it shows that DP2 had the higher mean days of it, about 5.41 days as well. And then in terms of definitive catheterization, only 3 patients needed catheterization at the 6-month follow-up. So they only followed up these patients at 6 months, and that was one of the limitations that was mentioned in the paper. So 1 in the superficial parametrectomy group, 1 in DP2 group, and 1 in DP3 group. If we go to the next slide, please. In terms of neurolysis, we can see that neurolysis were performed in 9 patients. Most of them were performed in the DP1 group and the DP3 group. in terms of nerve ablation of the hypogastric nerve, inferior hypogastric or the inferior hypogastric plexus. This was done in 11 of the patients, and this was only unilateral, predominantly on the left. So you can see 4 in the DP1 group. So mainly in the DP1 group, actually. And then if we go to the next slide, they looked at the functional outcomes. So they look at the KESS scores, and there was statistically significant difference between the baseline score and the 6 months follow-up in all of the groups apart from the DP2 group score. In terms of the GI quality of life score, they showed no improvement of the scores after the surgery, which was very interesting. And then in terms of their sexual function score, which was measured using the FSFI score, they found that despite an improvement in dyspareunia, there was no improvement in sexual function. So the conclusion of this study is that surgical extension of parametrectomy, despite the use of nerve-sparing techniques, can produce a non-negligible rate of bladder voiding deficits. And the results also indicate that parametrectomy in itself was not associated with an improvement in sexual function, but only in dyspareunia. And that's all from me.
Well, thank you very much, Avril. We are 10 minutes over time, so I'm going to close. And first, I would like to thank Professor Houdelis. That was a very interesting, very thought-provoking presentation. And just mention before I close that Alan made a comment about the anatomy. I think it's worth mentioning that IMA itself is actually a very short artery that very quickly gives off branches, sigmoidal, left colic, and the middle, the superior rectal. Middle rectal comes from the internal iliac. And it's sometimes difficult to know which branch you're taking. The idea is you take as little as possible and as distal as possible. If you have to take it, you really take it as distally as you can, and therefore not interrupt too many vessels, if possible. So thank you again, everyone. Thank you, the panel, for choosing and presenting these nice papers. And don't forget to join us 6th of every month. We try not to miss any. 6th of every month at 6 p.m. UK time. Doesn't matter which day of the week it falls on. We will always do 6th of every month at 6 p.m. It's free to register. Please spread the words. And if you want to present, and if you have, you know of a good paper that has been published and the author wants to present, please let us know. Thank you very much.
Is it,
yes?
Is the link spread via the EL site? How is it spread?
Both it is on the EL site as well. Alan, maybe you want to explain this for the audience that want to go through EL site.
Yes, so basically we're relying on EL social media to spread the word about Legendo. So it's on Facebook, it's on LinkedIn, it's on Instagram, and we also put it on the website. However, we're in the process of remaking the website, so you might not get all the updates from the website, but from social media from in the upcoming months.
I think that's something we can improve on. Maybe we should just register a domain called legendo.org or something like that, and divert into the EL website for registration, or STOR's website for registration. But yes,
Sure.
Please spread the word. And next month we have Professor Pados, George Pados, talking about adenomyosis and infertility. And I think the month after we have Dr. Shabo. Is that right? On nerve, or is it the month after that?
Let me double check.
Yes, I think it is Gabor, who's going to talk to us about detecting endometriosis of the pelvic nerves using ultrasound scan, which is going to be really interesting. Okay, perfect. Thank you very much.
Thank you very much, all of you.
Okay, bye for now.
Okay,
Yes,
bye-bye.
bye.